Today we're going to be talking about pregnancy in Hypermobile Ehlers-Danlos Syndrome and the Hypermobility Spectrum Disorders. Hi, I'm Dr. Clair Francomano, and this is my YouTube channel where we talk about all things related to the Ehlers-Danlos syndromes and hypermobility spectrum disorders. In general, pregnancy in hEDS and HSD is usually very well tolerated, and the outcomes are usually good. In fact, some people with hEDS and HSD find that they actually feel better during pregnancy because the increased circulation blood volume during pregnancy helps improve some of their symptoms of postural orthostatic tachycardia syndrome and other symptoms related to dysautonomia. There are a few things, though, that are increased risks of pregnancy for women with hEDS and HSD. Some pregnancy-related issues that women with these disorders may encounter are things like preterm labor, cervical insufficiency, where the cervix of the uterus dilates before the end of the pregnancy, a breech presentation. It's possible during the course of delivery that if an episiotomy is performed, that there can be tearing of the tissue in the perineum, and that tearing can extend into the rectal area, which can be a very serious problem. And if a C-section is performed, there may be slow healing of that cesarean section. Some less common complications of pregnancy are premature rupture of membranes, where the water breaks before the baby is fully developed. The aortic root may also dilate. That's the aorta of the heart may dilate in the mom. And it is also possible to see prolapse of the bladder and uterus after delivery. So in general, just a few recommendations for people going through a pregnancy with hEDS or HSD. An ultrasound can be done, transvaginal ultrasound, at about 16 to 20 weeks to look at the cervix and make sure that it is nice and tight and not dilating early. An echocardiogram for the mother in the mid-trimester is a good idea, just to keep an eye on the aortic root. Careful monitoring of the pregnancy for premature rupture of membranes, and just to be aware that this is something that can happen, is important. I usually recommend that people get an anesthesia consultation well prior to delivery, because many people with EDS and HSD are not sensitive to local anesthetics, and so it's important for the anesthesiologist to know this well ahead of time and to plan in advance for how anesthesia will be managed during delivery. If a cesarean section is done, closure with a double layer of sutures and putting those stitches a little bit closer together and leaving them in just a little bit longer will help with the wound healing. I recommend avoiding a routine episiotomy, often because of the extra stretchiness of the skin. It can be avoided, and this, of course, is up to the discretion of the gynecologist. But if it's not necessary to do an episiotomy, probably better to avoid that. We like to avoid traction on the umbilical cord as the baby is being delivered to avoid the risk of prolapse of the uterus as the baby is coming down. And then we also want to try to avoid forceps or vacuum extractions to decrease the risk of trauma and increase bleeding. Again, in general, pregnancy outcomes are usually good for women and babies with hypermobile Ehlers-Danlos syndrome and hypermobility spectrum disorders. So I would be reassured, and just to be on the safe side, take these considerations into account and just be aware that there are some increased risk and try to plan for those accordingly. Thanks so much for your time today. I wish you the very best on your journey.